Okay, so without further ado, I'm just going to introduce Yvonne O'Mara. So Yvonne is a systemic psychotherapist and psychosocial oncologist. She's worked as a medical social worker in psychosocial oncology and palliative care since 2004 in teaching hospitals in Ireland and North America. Yvonne is the co-founder of the Irish Society of Gynaecological Oncology Public and Patient Involvement, which in 2025 won the International Gynaecological Cancer Society Dicey Scroggins Distinguished Advocate Award. Yvonne has an expertise in supporting and promoting patient-led research. Her special interests are anticipatory grief, bereavement, and psychosexual dysfunction post-cancer diagnosis. Yvonne is the Engaged and Research Manager for Precision Oncology Ireland 2 at Systems Biology Ireland based in UCD. And in her spare time, Yvonne can usually be found juggling family life and acting as chief chauffeur to her 3 daughters. Yvonne, thanks so much for joining us today. Really looking forward to your talk.
Thank you, Erin. I'd like to say that lovely introduction, but when you realise you write it yourself, then I'm not sure. But it sounds good on paper. So thank you very much for giving me the opportunity to have what I hope is a discussion later on about what I'm about to present to today. As you can see, I'm embedded in patient-led research, and today we'll touch on this, and I hope we'll showcase some of the wonderful outcomes that can happen when we start listening to our population group. And perhaps for some of you, it's second nature, you do it all the time, and perhaps for others, you may dabble in it. But I'm here to demonstrate that quick wins are often the best wins when it comes to listening to the patient voice. So I'm going to start the presentation looking at the role of public and patient involvement or engagement. So, sorry, there we go. So I'm assuming that all of you know, but maybe some of you don't, but it's most commonly known as public and patient involvement or public and patient engagement. And the role that I've recently taken up, we're calling it engaged research because it encompasses a lot more than just public and patient engagement. So the term public refers to any person who uses the health or social care services, including members from your organisation. And PPI generally are volunteers who join a group or an organisation where they can use their expertise to influence research, national guidelines, and influence the future for them and others. I suppose it's important to say we can hold multiple hats as we navigate the healthcare system. So perhaps some of you today are also patients. And some of you are not. You're members of the public as well as holding a position within the healthcare system. And it shouldn't preclude or exclude you from participating in public and patient events. And the reason being is one of the therapeutic tools that I use within my practice is called the Johari window. And this is I suppose, an incredibly helpful tool when working with public and patient engagement. And so there are things that you know about me that I've just demonstrated there in my bio. And there's things that I know about you just by you showing up here. But then there's a blind spot that is particular to both of us. So there's things that I don't know about you that you know about me, and there's things that I know about you that you don't know about yourself. And then if you put all of those voices together, there's a mass of unknowns. But that's actually where the brilliance occurs when it comes to public and patient engaged research. And so it's really important to not underestimate the unknowns that you hold and that I hold. So PPI is not, you're not a guest in it. It is a marriage, and to truly embed public and patient involvement or engagement, it is really to nurture that relationship. And so if you're considering in doing research, it's important that they're there from the start. A relationship doesn't happen as you just walk up the aisle. It's happened many months or years before that time. And so that's how PPI should be perceived. It's not your opinion is important to me. I'll make note of it. your opinion is as important as mine. And that can be a shift for some of us, irrespective of. So you are an expert in your area, but they are an expert in being a customer of the healthcare service. And that's not to be underestimated. So often it's about reading the room. So why don't you tell us? Assume nothing. So often people find it, I suppose, fearful to express what it is that they observe or that how and they often suffer needlessly going through the healthcare services. And in a PPI setting, they can often see how we can improve things in a way that we don't. So really delve into the things that can often be a little bit murky that perhaps we don't want to hear, and maybe we don't have a solution, but the very fact of creating a space to articulate it can maybe in due course allow us to advocate or articulate for change. So you're not only are you a lazy cow, you have a graph to prove you're getting lazier. So I often hear professionals working in the area that it's really hard to incorporate all of these voices into the arena of research. And what I would say to you, and what I hope, as I say, to showcase to you today, is that it really is worthwhile doing. So what you do is often people stick to their lane. And what's required in public and patient involvement is that you actually allow the pinball to go over to the other person's lane and they go over to your lane. And it's with that is that you'll get a full house. It's with that you will get the richness and the greatness to the research that you're doing. And this is also with pertaining to even forming research questions. Including their voice at that stage can be incredibly helpful. So the values and principles of PPI: equity and inclusion, as I said, flexibility when you're engaging with public and patient involvement. It does require often to work off grid, which is something that all of you do in your own profession anyway. Empowering and power sharing, transparency, respect, trust, and collaboration and partnership. And if you have that ingredients in the bowl, I guarantee you success will endure with whatever it is that you're about to research. So I had an idea for years and years, but 5 years ago, when I took up the position as the Women's Health Initiative coordinator, which was funded by the Irish Cancer Society, as you know, when you tell bad news within a setting, people don't retain the information. In fact, as much as 80% can be lost in that exchange. And as a social worker, I witness this all the time. People, and I may have been present at those meetings where bad news was delivered, being told you have a cancer, being told the stage, the grade, and people would come out and not retaining any of it. And so I had an idea that could we make this easier? Could we give patients a piece of paper like the same size as a credit card, just with information on it, such as their medical record number, their provisional diagnosis, often it goes to MDTs, as you say, after they've initial consultation, then the confirmed diagnosis, the stage, according to FIGO, the grade, and the histology. This is within the gynaecology space. So I put an open call out to the group that I founded, the thisisGO PPI group, and a huge response. I think I had 20 patients wanted to be part of this project. So I'm very transparent. So I picked the first 6 and we held a workshop. And so I floated the idea. Initially, on the back of the card, I had helpful numbers like the Irish Cancer Society, and the patients were, no, I don't want that. I can Google that. But what I do want is, I want to know who I saw today, and I want to know who's the person I contact after I leave the room. So we changed, and the card reflected this. But during that conversation, one of the patients said, she was 10 years out. She was a cervical cancer a patient. And she said, 10 years ago when I met my consultant, they drew a diagram for me on my anatomy as to explain to me where the cancer was within the cervix and where my cervix actually was. And she said, I still refer to that drawing to date as I go back to it and I take it out when there's other parts of my body being, she suffers from chronic bladder and bowel issues as a result of radiotherapy toxicity, which says I still refer back to this drawing. And so I thought, oh my goodness, this is genius, because like her, I'm somebody who likes to do things visually. I like to see things. So if I'm told a name, I prefer to write it down, then I'll retain it rather than being introduced and not doing it. And obviously that's a big complication for me because you can't always write down the name that you meet with somebody, but I prefer to see things on paper. And so we constructed this with the patients. So for the 5 gynecological cancers, which are ovarian, cervical, vulva, vaginal, and uterine, there's one of these for each of those cancers. And essentially, in all of accredited hospitals now in Ireland, any gynecological patient should be getting one of these. I did a roadshow about 3 years ago, giving everybody books and then how to reprint them. And so everybody gets a copy of this, and a copy goes into the file. So there's a tracing kind of a tracing paper behind it. So one goes into the file and one goes into is brought home to the patient. And so what you have is you have a visual aid for the patient describing where their cancer is. You can see they can put the patient sticker there. We've gotten rid of the card. You've stage and grade there. The doctor can write their name if they choose, but also it helps with what the procedure is, what the surgical complications are, and what the radiotherapy side effects are. So it's improving consent, or so the hypothesis was before we evaluated them. And so what we found is that people were incredibly satisfied with this. I called 20 patients and they were very, very supportive of the project. What we also found is that it helped as a memory aid. So people, again, as I said, over 80% of information can be lost. And so they found it helpful going back to their significant others or their daughter or their son and saying, oh, this is the type of cancer that I have, and this is where it's at. I presented it to ESGO, that's the European Society of Gynaecological Oncology, in 2023, and it won the Project of the Year. And so this is the Hungarian version of it. It is now rolled out across all accredited ESGO centres across Europe. And I'm pleased to say there's a little picture of me there back in Copenhagen 2 weeks ago, where all of the diagnosis deliveries were there as you registered, which is really amazing. So while I was doing that project, it was always part of the plan to develop a personalised website for what we've called thisisGO.ie. And the idea being, if they now are getting that information on diagnosis, they now know their stage and their grade, and it will make the platform more easy to navigate. And so it's a multimodal platform. But at the start of it, again, I put an open call out, and the purple is the level of engagement that it took. So I met with them over 12 times before I finally launched thisisGO in 2021. So there was, from every aspect of this website was developed and co-designed with the public and patient. And so as I say, all of the 5 gynecological cancers are covered, as well as BRCA and the Lynch syndrome. And what we realised as well is that a lot of healthcare professionals were using it, so we also created a healthcare pathway for healthcare professionals as well. So this is just the flow that occurred with the engagement of public and patient involvement. And I suppose the richness I would have had 5 members of PPI in every single strata of those. So I engaged with over 30 public and patient involvement members. So And each workshop that I ran, I obviously became much more efficient towards the end. So I may have only engaged with them 3 times before the launch of their particular disease. And then we do a soft launch where the patients would observe, see what we missed out on, and then we'd do an official launch after they gave us their feedback. So, for example, in the BRCA pathway, what was really important for them was having a topic about insurance and the effects of trying to get house insurance, life insurance when you have a BRCA mutation. So, but that hadn't been identified with the cervical cancer patient population. So there's richness in including multiple voices in all of the projects and pathways. So this is what it looks like if you landed on the homepage of thisisGO. So you can see you have to create a profile and you have to give your stage of cancer, and then it will direct you to specifically your needs. So it'll ask if you're pre-operative, whether you're post-operative, whether you're in survivorship, whether you're palliative, and it'll give you a bespoke of your side effects, of your psychosocial needs, psychosexual needs. So there's thousands and thousands of articles, and I engaged with over 120 professionals, both nationally and internationally, to populate the platform. So, for example, you sign in there, you select your disease, and then you create your profile. So to date, this was done in January. So we are consistent with regards our profile creations. So 20% conversion rate. So what this actually means is, if like you, or if you, like me, you do a lot of online shopping, statistically it tells us that I will go to a site multiple times before I purchase, and my chances of purchasing is 7%. So there's a 7% conversion rate that I will go on a site and actually make a transaction. So whether that's creating a profile or buying something. And so what we know with thisisGO is we have a 20% conversion rate. And it is so consistent that I could, at the start, pinpoint when people were having outpatient appointment clinics running around the country, because I could see there would be a surge in Dublin on a Tuesday because such and such championed the website and created 5 profiles that morning for the patients that it was applicable to that morning. Or there was an outpatient appointment clinic on a Thursday in Cork, and I could see that 4 profiles were created that day in the southern region. So it's Google Analytics is really helpful for pinpointing this. And so what we know is there's been 192,000 page views, there's been 9,200 create profile visits, and the conversion rate, as I said, is 20%. So what are people interested in? So the most popular cancer to date has been cervical cancer. This was also the first profile that we created. And so for some, it might be a little bit skewed because I would have created a profile in cervical cancer just to see how the flow and operation was of it. So we suspect that the real figure is probably 100 less than that. Then ovarian cancer is very strong, uterine, vulva, vaginal, as you would expect, and BRCA and Lynch. And so what are people interested in? So overall, across all of the disease sites, so diet and exercise is proving to be the most popular. Patient stories is the second most popular. Menopause, decoding the science is where we bring the latest research papers and we break them down into layman's terms. Psychological wellness, financial matters, surgery for ovarian, sexual wellness, recurrent cervical cancer, and lymphedema. So a lot of quality of life stuff that people are swimming in. So we did a short survey on the effectiveness of thisisGO, and 134 people replied. So was a 2-to-1, so personal use, so 50% were personal users and 50 were healthcare professionals, and there was a very positive, over 80% were likely to recommend thisisGO. So how useful, 38, very, 43, likely to recommend, 73, and 47. So the take home with regards to public and patient involvement is that it fosters collaboration between healthcare providers and patients. So I have huge buy-in when I put call outs for any project that research may approach me for, because people see that we've delivered. And these are soft sciences. These are quick wins from a patient's perspective, but the output is significant and huge and tangible for them. So they see it. So unlike some of the things that happen in the laboratory where it's very remote for them, these are very, very relatable. So it engages patients and it allows their perspectives to inform healthcare decisions. So you can see we buy in and build up with the website from the patients, which no doubt has led to their usability of it, their endorsement of it, but also the success of it. It ensures services are responsive to patients' needs, and if you feel listened to, everything else pales. It's really important. It engages trust in the healthcare system, and it encourages adherence to treatment plans and promotes more equitable health outcomes. And then last year, I was approached by the Department of Health on the back of thisisGO to design a website for cervical screening, which is mycervicalscreening.ie, which was launched in January. And again, I did exactly the same thing as I did with thisisGO. I worked from the ground up and I engaged with the patients or those who are engaged in the cervical screening program, those who are not, why are they not? And I also engaged with the marginalised community, the travellers community, and gave them a separate pathway as well. So if we have the correct infrastructure and no sinkholes, it genuinely leads to greatness. And I cannot stress that enough. So if you take one thing home, it is think of their voice as you proceed in whatever piece of research that you are involved in, and get them involved. And of course, behind me is a team of magnificent people. So I'm very grateful for their support over the years. Thanks so much.
Thanks so much, Yvonne. That was fantastic. A really great overview of the impact of well-designed PPI into research. So as I said earlier, we're just going to leave all the questions to the end, but if you have any questions for Yvonne on that presentation, please just pop them into the chat now if you wish, and then we can have a Q&A after Zibi's presentation. So I'd like to start the next presentation and introduce our second speaker. Dr. Zibi Marchocki is a consultant obstetrician and gynecologist and subspecialist in gynecologic oncology. He completed a 3-year fellowship in gynecologic oncology at the University of Toronto with advanced surgical training at Princess Margaret Cancer Centre, Odette Cancer Centre, and Toronto General Hospital. During his fellowship, he developed extensive expertise in complex oncologic surgery of the female reproductive tract using open, laparoscopic, and Da Vinci robotic approaches. Dr. Marchocki graduated from Warsaw Medical University and completed both basic and higher specialist training in obstetrics and gynecology with the Royal College of Physicians of Ireland. He subsequently served as clinical research fellow and academic lecturer at St. James's Hospital and Trinity College Dublin, where he was awarded a Doctor of Medicine degree for his research on recurrent cancer-associated thrombosis. Following his fellowship, Dr. Marchocki was appointed consultant obstetrician and gynecologist at CUMH and Bon Secours Hospital Cork, where he currently practices. He is also the program director of the ESGO accredited fellowship in gynecologic oncology at Cork University Maternity Hospital. He's a member of the European Society of Gynaecological Oncology, the Society of Gynaecologic Oncology of Canada, and the International Gynaecologic Cancer Society. He holds membership of the Royal College of Physicians in Ireland and membership of the Royal College of Obstetric and Gynaecologists. He has published extensively in leading peer-reviewed international journals and will be presenting to us today on the clinical surgical survivorship in gynecological oncology. Thanks so much, Zibi.
Thank you, Erin, for this kind introduction. Before I start my talk, I would like to thank Yvonne as well for her fantastic talk and for all the work herself and the team does on the ESGO resources. This is amazing resource for our patients, and obviously a huge thank you for that. I would like to start this talk with a quote that our goal is not a maximal surgery, but a maximal patient benefit with a minimal unnecessary harm. And today our focus is shifting towards balancing oncologic safety with a long-term quality of life. So why does survivorship matters? Well, the large US surveillance, epidemiology, and end results database showed that over the last 40 years, survival rates from gynecologic cancers are improving, patients are living longer after treatment, and long-term surgical morbidity is increasingly recognized. So when we think about survivorship in gynecologic oncology, the surgical decision we make at the beginning of treatment can have a long-term consequences for our patients. And several key factors influence this decision. First, the tumor biology, the histologic subtypes and molecular profile are increasingly important. These features help us understand the tumor behavior and also the likelihood of response to chemotherapy or targeted therapies. And in some patients, systemic treatment may be particularly effective, which can influence the timing or extent of surgery. Second is the disease distribution. Preoperative imaging help us evaluate the anatomic distribution of the disease and importantly, whether a complete cytoreduction is realistically achievable. Our goal is always obviously a complete resection of a macroscopic cancer, but we must balance this with the risk of pursuing radical surgery when the likelihood of success is low. The third is the patient-specific factors. This includes frailty, comorbidities, and the patient's ability to recover from major surgery, which are critical considerations. Two patients with the same disease may tolerate the surgery very differently. And finally, patient values and survivorship goals. Increasingly, we also need to consider what matters most to the patient. And this includes preservation of sexual function, fertility in younger women, maintaining body image, as well as minimizing the long-term toxicity. So in this presentation, I will highlight several developments across the main gynecologic cancers that are shaping survivorship today. Starting with cervical cancer, recent trials such as SHAPE trial and GOG27H are exploring less radical surgical approaches for carefully selected early stage cervical cancer patients. And the goal is to maintain the oncologic safety while reducing treatment-related morbidity. Another important aspect is ovarian transposition, which can help preserve ovarian function in young women undergoing pelvic radiation and therefore reduce the long-term effects of premature menopause. Then moving on to endometrial cancer, surgical management has evolved significantly with the introduction of sentinel lymph node biopsy, which reduces the risk of complications such as lymphedema compared with full lymphadenectomy. In addition, robotic surgery has improved perioperative outcomes and recovery. And at the same time, molecular classification systems such as thisisGO.ie and PROMISE allow us to better stratify patients into biologically distinct subgroups, including polymutated MMR deficient, P53 abnormal, and non-specific molecular subgroup. This molecular approach is increasingly guiding our personalized treatment decisions. And finally, ovarian high-grade serous carcinoma. This is a highly heterogeneous biology cancer which influences both treatment strategy and survivorship outcomes. One key debate remains about the role of primary cytoreductive surgery versus neoadjuvant chemotherapy. And the recent TRUST study has shed some light on that topic. From a biological perspective, tumors with homologous recombination deficiency or BRCA mutations tend to be more chemosensitive and respond to PARP inhibitors therapy. And finally, prevention strategies are also evolving with studies such as TUBA-WISP exploring approaches to reduce ovarian cancer risk while maintaining the impact of early menopause. Before discussing the SHAPE and GOG27H study, it is useful to reflect on the extent of surgery traditionally performed for early stage cervical cancer. As shown on this diagram, a radical hysterectomy involves significantly more extensive resection compared with simple hysterectomy. In addition to removal of the uterus and cervix, the procedure includes resection of the parametrium, uterosacral ligaments, and upper portion of the vagina. And surgical specimens shown here illustrate how radical this operation can be, with a substantial amount of surrounding pelvic tissues removed to ensure oncologic safety. While this approach has historically been standard of care for early stage cervical cancer, it is also associated with important long-term morbidity, and that includes bladder dysfunction, sexual dysfunction, and obviously impacts on quality of life. So this raised important question: do all patients with early cervical cancer truly require such radical surgery? And this question is precisely what recent studies, including SHAPE and GOG27H, have sought to address by evaluating whether less radical surgery may provide comparable oncologic outcome while reducing treatment-related morbidities. The SHAPE trial was a randomized phase 3 study comparing simple hysterectomy with radical hysterectomy in patients with low-risk early-stage cervical cancer, specifically tumors 2 centimeters or smaller. And the trial demonstrated that simple hysterectomy was non-inferior to radical hysterectomy in terms of pelvic recurrence, suggesting that radical parametrectomy may not be necessary in this carefully selected patient population. Now, importantly, patients undergoing a simple hysterectomy experienced lower bladder dysfunction, had shorter operative time, less surgical morbidity, better sexual function, and improved post-operative quality of life. So overall, these findings support de-escalation of surgery for selected patients with early cervical cancer, which has important implication for survivorship. The GOG27H study was a prospective international study evaluating non-radical surgery for early stage cervical cancer, specifically comparing cone biopsy with pelvic lymphadenectomy and simple hysterectomy. Out of 224 patients included, 3 patients experienced recurrence. Those were in a cone biopsy group, which were successfully salvaged with a subsequent simple hysterectomy. The pregnancy outcome was, the pregnancy desired was sought by 31 patients. 16 pregnancies were achieved with 9 full-term pregnancies. So overall, the study demonstrates that non-radical surgery is safe, associated with low morbidity, and can allow for fertility preservation, though careful follow-up is required to detect rare recurrences. Another important strategy to preserve survivorship, particularly ovarian function, is ovarian transposition prior to pelvic radiotherapy. And this includes cervical cancer, but also non-cervical cancers, pelvic tumor requiring radiotherapy. And as shown in this diagram, the ovaries are mobilized and transposed laterally and superiorly out of the pelvis and the radiation field to the upper abdomen. The images on the slide show the actual surgical outcome of the transposition to the left and right upper abdomen, demonstrating how the ovaries are positioned away from the pelvis. And clinically, ovarian transposition preserves endocrine function in premenopausal women, reduces the risk of premature menopause, and obviously the long-term consequences associated with surgical or radiation-induced ovarian failure, such as osteoporosis, cardiovascular risk, and quality of life impact. Moving on to endometrial cancer, robotic-assisted surgery has become an important strategy to minimize surgical morbidity, particularly in a challenging patients population. On this slide, you can see the evolution of the Da Vinci robotic system alongside an example of a patient with a significant obesity. Now, these cases highlighted the technical challenges of a traditional open surgery in a complex environment. So robotic surgery provides enhanced visualization, precision, and dexterity, which obviously all allows surgeons to perform complex procedures in a minimally invasive way in patients with high BMI. And the benefit of this surgery includes smaller incisions, reduced blood loss, shorter hospital stay, and a faster recovery, which obviously translates into improved survivorship, but also can facilitate earlier initiation of adjuvant treatment when needed, improving the overall outcome. In endometrial cancer, the concept of a sentinel lymph node biopsy has transformed surgical staging. Traditionally, a full pelvic and para-aortic lymphadenectomy was performed, but this approach carries a risk of lymphedema, intraoperative nerve injury, and vascular injury, as well as a longer operative time. A sentinel lymph node mapping allows us to identify the first draining lymph node from the uterus using tracers such as indocyanine green, ICG for short, which fluoresces under near-infrared imaging. And on this slide, you can see the ICG hot sentinel lymph node during laparoscopic or robotic surgery, and targeted removal of these nodes provides accurate staging while significantly reducing morbidity compared to a full lymphadenectomy. And several studies, including those validating the FIRES study and systematic review that we have published, has shown that sentinel lymph node biopsy is highly sensitive for detecting metastasis and can be safely implemented in both low-grade and high-grade endometrial cancers. And in fact, the detection rate of lymph node metastasis with the sentinel lymph node biopsy is improved. And this is also to do with the ultra staging techniques that can be employed by histopathologists, which is a more detailed examination of the lymph node. So when the histopathologist receives a lymph node, they receive 1, 2, 3 lymph nodes compared to 20. So obviously they can examine them in much more details versus all of the lymph nodes that are sent with full lymphadenectomy, detecting much more smaller metastases, including isolated tumor cells and micrometastasis. And beyond the surgical staging, the molecular classification is becoming a cornerstone of personalized care in the endometrial cancer. Large-scale genomic studies such as the Cancer Genome Atlas identified distinct molecular subgroups which have been later clinically simplified by the PROMIS classification into 4 distinct subgroups, that's including poly-ultramutated group with an excellent prognosis, a mismatch repair deficient group with intermediate prognosis that may respond to immunotherapy, P53 abnormal group, which is a high-risk group that poorly responds to treatment with a poorer outcome, and non-specific molecular profile with intermediate prognosis. And understanding a patient's molecular profile allows us to tailor adjuvant therapy, avoiding the treatment in low-risk subgroups while intensifying treatment in high-risk patients. The PROTECT-4A trial, which was recently published in Lancet Oncology, provides a strong clinical evidence supporting the use of molecular classification to guide adjuvant therapy in early stage endometrial cancer. And in this trial, patients were assigned to a therapy tailored to their molecular profile, which included a poly-mutated MMR deficient, p53 abnormal, and non-specific mutation group. Importantly, the 5-year vaginal recurrence rate in the molecular guided group was 4.5%, compared with 1.6% in the standard therapy group, and the difference fell well below the predefined non-inferiority margin, confirming the molecularly tailored therapy does not compromise the oncologic outcome. And the take-home message from this study was that the molecular profile-guided therapy is safe and effective. It supports personalized adjuvant therapy based on tumor biology, and it also reduces overtreatment while maintaining excellent vaginal control. Building on the molecular classification data from the PORTEC-4 study, this slide shows that thisGO algorithm app for endometrial carcinoma, which integrates tumor molecular profile to provide evidence-based guidance for adjuvant treatment. As you can see from the screenshots here, that illustrates how the app incorporates the polymutated MMR deficient and p53 abnormal groups together with the traditional clinical pathological risk factors to recommend the tailored adjuvant therapy. And obviously, this digital tool allows clinicians to quickly identify the optimal treatment pathway for each patient, ensuring that therapy is personalized based on their molecular biology, but also the traditional clinical risk factors, while minimizing the overtreatment. Now shifting focus to ovarian high-grade serous carcinoma, which is biologically heterogeneous and presents unique challenges for both treatment and survivorship. Now, surgical strategy remains central in treating this type of cancer. The key question that has been around for a long time was whether to perform a primary cytoreductive surgery or start with neoadjuvant chemotherapy, allow the cancer to shrink, followed by interval cytoreductive surgery. And this topic has been explored and answered by the TRUST trial of radical upfront surgical therapy in advanced ovarian cancer that has been presented at ASCO meeting last year and is being prepared for publication. It has included or randomized 688 patients into 2 groups: primary cytoreductive group versus neoadjuvant chemotherapy, followed by interval cytoreductive surgery. And although progression-free survival was slightly higher in a primary cytoreductive group, the overall survival was not statistically significant between the 2 groups. And the key message out of this study was that the best outcomes is in patients with complete cytoreduction, meaning removal of all the macroscopic disease, and that's regardless whether patient has primary cytoreductive surgery or whether patient goes on to have the chemo first, followed by surgery. Tumors with a homologous recombination deficiency, HRD for short, or BRCA mutations are highly chemosensitive and respond well to PARP inhibitors. And in frontline maintenance, the SOLO-1 trial demonstrated dramatic PFS benefit for BRCA-mutated patients after first-line platinum chemotherapy. The PRIMA trial showed that niraparib also benefits HRD-positive patients, even if they do not have BRCA mutation. And PAOLA-1 trial combined olaparib with BEV and showed the greatest benefit in the HRD or BRCA tumors. And in the recurrent settings, platinum-sensitive settings, SOLO-2 and NOVA trial confirmed that the PARP inhibitors improve progression-free survival in both BRCA-mutated and HRD-positive subgroup. Now, while early detection of ovarian cancer is challenging, large screening trials such as PLCO and YUCTOS trial have shown that screening alone has a limited impact on mortality. And for women at high genetic or familial risk, the most effective strategy remains risk-reducing surgery, specifically laparoscopic bilateral salpingo-oophorectomy, which removes the fallopian tubes and ovaries and significantly reduces ovarian cancer risk. However, this obviously causes immediate surgical menopause. And with this in mind, and the factor that the ovarian cancer actually originates in the fimbrial end of the fallopian tube, the centers in MD Anderson and Netherlands came up with the idea of tuba-wisp studies, which explore a risk-reducing approach for premenopausal women at high genetic risk, such as BRCA mutation carriers, who wish to preserve ovarian function. So instead of performing immediate bilateral salpingo-oophorectomy, the strategy involves early removal of the fallopian tubes while delaying oophorectomy until closer to the natural menopause. And this approach is based on the understanding, as mentioned earlier, that the most high-grade serious ovarian cancers arise in the distal fallopian tube. So removing the tubes early significantly reduces the cancer risk while maintaining the hormonal function and fertility. And we run a gynae cancer risk reduction clinic in CUMH, and this is led by our ANP, Ms. Vicky Cleary, and we enroll patients from that clinic into the study. And I'm happy to say that we have enrolled 20 patients already, and that's including referrals from Dublin, as we are the only Irish center open for this trial. So as we look to the future, the key question is what is next? Now, advances in molecular profiling, minimally invasive surgery, and targeted therapies have already transformed the care and survivorship for our patients. But the next frontier will ultimately involve integrating artificial intelligence, digital health, and precision medicine into everyday clinical practice. Now, a few months ago at the World Economic Forum in Davos, Elon Musk made this comment that soon enough the robots will outnumber humans, and we should all expand our focus on AI and automation. Later on, he made the claim that in 5 years' time, robots will replace even the best surgeons. Now he corrected that claim. He said that actually this will happen in 3 years' time. And he also stated that it's not necessary to go to medical school anymore because it will be pointless. Now, I'm not sure whether I would go that far with the comments. However, while the other comment sounds very futuristic, we are already seeing the early stages of this reality. Now, in Beijing, a few months ago, the single port Da Vinci robot was able to peel autonomously was able to peel a raw uncooked egg with the egg body being completely intact, then purposefully was able to rupture and suture it with very fine sutures. More recently, a group in Johns Hopkins Hospital were able to show a fully performed autonomously by a robot cholecystectomy in all stages, and this was done by the robot that was trained with a video-based imitation learning and language guidance. And the robot responded to voice commands and was able to adapt in a real time, mimicking the trainee-mentor relationship. Now it achieved 100% accuracy across various anatomical and unexpected scenarios with a comparable performance to an expert surgeon, although the operative time was slightly longer. So my cancer is gone, but my life has never been the same. I think this quote reminds us that survivorship is more than the absence of the disease, that our work in gynecological oncology is increasingly focused on not only on cure, but also on long-term quality of life, functional outcomes, as well as patient-centered care. And with this quote, I would like to conclude and thank you very much for your attention.
Thank you so much, Zibi. That was fantastic. A really detailed overview as to what is happening in the various cancer spaces for gynecological oncology. So I'm going to go to questions first. Again, if anybody would like to pop a question in the chat, we have one that came through for Yvonne first. Thanks, Yvonne, for a great talk and for all your incredible work. Do you have any thoughts of the role of establishing a research PPI panel at a hospital level, or anything to help guide the general governance of research and to have as a potential panel for specific research projects?
Yeah, and for that conversation or that question.
Oh, you've gone back on mute there, Yvonne.
Sorry, apologies.
There you go.
What I would say is, it's very handy to have a patient panel or patient population. So 2 seconds, my dog is barking. I just sorry, typical. Sorry. So what I would say is it's really important that hospitals have their own patient and public cohort, not necessarily a separate silo for, one particular cancer disease or another, because what we tend to have then is we've silos, and that's not great with regards public and patient involvement. But what if you were to set up one, Claire, you have to put the infrastructures in situ, that you have an educated public and patient panel that knows what research is, how to read a research paper, what are you looking for, what does the stats mean, what success look like, what success doesn't look like, managing expectations. And that could be difficult to set up in a silo, as you're suggesting. So I would look to existing PPI cohorts. So like in UCC, you have UCC PPI Ignite, and I would perhaps go to them and see, could they support you in some of the training? Maybe they have existing public and patient populations that have attended Cork University Hospital, and see, is there some way that you could have some overlap so that you're not making a huge amount of work for you, but that you have the infrastructure to support those that self-select to your call out. So I hope that is helpful.
Thanks, Yvonne. Actually, it kind of leads on to one of the questions that I was going to ask you, and it's about responsibility for PPI. So I think it's changed. Certainly, like, you have far more experience than me. I've been in research coordination for the last couple of years, but there's been a massive shift in terms of the from the funding agencies, I've noticed. So now there's not really any point in applying to the HRB for funding calls if you don't have really well described PPI at the center of your project, which is absolutely right. So I suppose in terms of progressing it even further, there's no point in reinventing the wheel, like that you have to have PPI for your project, and then Claire wants to set PPI up at her hospital level, and just all these variations of PPI panels. So in terms of the responsibility for ensuring it's there, I wondered, do you have any thoughts on who ultimately is responsible?
Yeah, it's really, I think it's a really complicated space at the moment, Erin. And on that, like 10% of precision oncology has gone towards engaged research. So that will tell you, of a 28 million euro grant, 10% has gone to engaged research. It is that valued. And so you need buy-in from the top down and the bottom up. But my role, so I'm currently putting a national call out, and I have the skill set to, well, I'll be led by what do the PPI feel is their needs, but there is no national training program. And there is an argument to say, well, we can't over professionalize the patients, so you can't, because then there's that, there comes with that difficulty too. But what's the happy medium? And I mean, I could give you my ideas, but I would like to come back at another time, maybe 3 years' time, after working with a national group of public and patient involvement, and see what they believe to be the best training to meet their needs. Because I could say to you, okay, like, say, for example, I'm meeting somebody this afternoon who's agreed to talk to pharma about their story, okay? Now, I might just let that person go ahead. But I wouldn't in a million years, because I have a rule book in that they don't mention doctors, they don't mention hospitals, they don't mention. But I've often witnessed PPIs on panels and conferences, and they're talking about clearly they haven't been prepped properly. So there's those little idiosyncrasies, and then there's the bigger piece of how we can support them to success rather than failure. And I don't have the answer, but again, I'd be going back to your established like PPI Ignite, seeing what training programs. We have IPOSI in this country. They send people and fund them to go to UPATI in Europe to get that professional training. But that's not everybody's story. Not everybody can do that too. So again, going back to Claire, like it's important that you meet with them, you see what they identify as their learning needs within the space, and then you try to find existing infrastructures that will support them. So say, for example, if you were doing we've often brought in gynaecologists to speak to our patient population to educate them on X, Y, and Z. So that's what you're hopefully trying to do. Sorry, hope that answers.
Yeah, to minimize resourcing as well. No, that's brilliant.
Yeah.
Thank you very much. Okay, some questions for Zibi. Excellent talk. Thank you both. Zibi, is molecular classification of endometrial cancer, including pole testing, available as standard of care at your centre?
So we are already testing routinely for MMR and P53. Poly testing is weeks away. I was told 7-8 weeks away. They're currently testing, and they're in the process of finding and choosing the kit suitable for that testing. So yes, it's not at the moment, but it will be hopefully in the near future.
Great, thank you. And also for Zibi, what challenges did you experience getting your prevention study open in CUMH, and were there any learnings for future studies in this area?
I think that the biggest challenge was the administrative part of bringing the study over, and Erin, who is present here, hugely helped us with that part, obviously. So I think the site, hospital, and everybody else involved was hugely supportive, but it's the administrative part that's the biggest challenge, and that's the most time consuming, because I think it took us more than a year from approaching the PIs to starting the study in CUMH. So without appropriate support like we had from UCC, we would not be able to do that.
Yeah, I think resourcing is really it's critical, and it's very unseen work in terms of legal requirements, data protection requirements, but that will ultimately be the difference in getting a study open or not. Brilliant. Okay, so from Dr. Mary Jane O'Leary, thank you, Yvonne. Fabulous work, progress made. Lots of food for thought in terms of how we are educating our patients on their illness and associated sequelae on an ongoing basis from a PAL care perspective. Lovely. And also, actually, I wanted to flag for that Tuba Wisp, the prevention study that is open in CUMH. They have published really fantastic work about how they came to their study and the PPI level in terms of how they wrote all their patient-facing documents. They've developed a really fantastic patient decision aid. It was one of the nicest I've ever read in terms of how they explained your risk for each type of surgery and what that actually meant in terms of the real world scenario, what the figures meant, coming from Radboud University. So it was really, really nice to see, that from the very beginning, Yvonne, it really incorporated and hopefully led to a really successful study. It is certainly recruiting really well in CUMH. Okay, so I'm just going to take this. Seems to be no more questions coming in. So I'd like to take this opportunity again to thank both our speakers, Yvonne and Zibi, on really fantastic presentations. And also just to shout out, our next Cancer Seminar Series will be on April the 13th. Our speaker will be Philip McCarthy of Loswell Park Comprehensive Cancer Centre, speaking on CAR-Ts for myeloma. If anybody's interested in that, then that will be circulated in the coming days or weeks. So we're finishing spot on time. So thanks very much to everybody, and really great presentations.
Thank you.
Thank you.
Thanks, Erin. Bye.